Hello everyone, thank you. Thank you for the invitation to join you and speak here at the LSX Investable. I'm here to talk about Epiendo, an Icelandic company focusing on a new way to treat COPD. And of course, this one will follow as always. So I'm not going to spend too much time on these slides. I think we can just agree that COPD is a big disease, and it shows no sign of getting smaller in the future unless something extraordinary happens. Like, for instance, everyone stops smoking, and I don't see that one happening either. So the only thing that has really been working for us for COPD over the last couple of years is actually azithromycin. That's the only thing that really shows disease-modifying effect for the patients. Naturally, you can't really prescribe azithromycin to long-term use because it's an antibiotics. And the funny thing with azithromycin is it actually works and improves the health of patients even though they don't have an infection. And this is kind of the cornerstone why this company was founded in 2014. Was a physician who prescribed azithromycin to a lot of patients, and he got really confused that they were improving so much in their disease, even though they didn't have infections. Being on Iceland, he of course called a close relative who happens to be a professor at the university, and they managed to figuring out that azithromycin actually has at least 3 different modes of action. One of them being as an antibiotic, another one being an anti-inflammatory agent, and the third one, and this is really the groundbreaking here, is actually strengthens the epithelium. So it strengthens the epithelium in the lung, and we believe that COPD is to some extent a misunderstood disease. You could argue, is it a disease at all? Because you don't really wake up one morning with a mutation in your body and you have gotten COPD. COPD, you actually have to work for it quite hard to get it. You either have to be a chain smoker, you have to work in a coal mine or living in a very polluted area. That's the only way to really get COPD, which of course means that what you are doing is that you are exposing your lung to wear and tear, which is either radicals, free radicals from oxygen, it's microparticles from air pollutions, it's acids, it's bases, and over the course lapse of time, this will cause a rupture in your lung. And what happens when the lung gets a little bit ruptured and you get a breakage in the lung epithelium, what will happen is that the body will send out granulocytes and macrocytes, and what that will be perceived as, if you're a lung physician looking down into the lung, is an inflammation. So we believe that this is why the industry has for a long period of time believed COPD being an inflammation disease. Of course, there has been a lot of anti-inflammatory agents being developed the last couple of years, and none of them has really made a disease-modifying effect in COPD. And we believe that this is just because you are treating the symptoms and you're not really treating the underlying cause of the disease, which is the breakage and the rupture of the epithelium layer. So to prove, we were struggling a bit how to prove our point, and then just this autumn we were lucky enough to find a poster at the European Respiratory Society meeting where a research group at Karolinska in Sweden actually developed a machine where they let people breathe radioactive nanoparticles, and then they take out blood samples over the course of time. And you can see to your right that in a healthy volunteer, if you're a healthy volunteer, breathe radioactive microparticles, there is no leakage of radioactivity to the blood. Whereas if the patient has COPD or IPF, you can see there is a huge leakage of microparticles to the blood. Now, of course, there is no active transport of microparticles from the inside of the lung into the blood. So the only way for this radioactivity to get there is actually to be that there is a rupture in the lung, and this is what we believe then is the cause of the disease. And this is what we try to treat. Starting from what we know, azithromycin works. It works really well. So as a starting point, we thought, why reinvent the wheel? Let's start with azithromycin. So we started here and used that as our, if you will, lead compound, and then we did medicinal chemistry on it. We took away all the antibiotic activity because we will be able to prescribe this for a long time. And at the same time, we also took the opportunity to increase the barrier enhancement properties as well while we're at it. So the main assay for readout is what we call transepithelium resistance. So what we're doing here is that we're growing lung cells in an air-liquid interface model. And you can see that for a few days of incubation, nothing really happens, and there is a reason for this. But after 5 or 6 days, you will really see that the cells, the epithelium, is really growing and becomes more thick. We have confocal microscopes on this one. We have done a bunch of RNA sequencing on all these cells, and so it's really an effect that it really strengthens the epithelium. So this is our base assay. We then move on to animal studies, and with our approach, being an epithelial company, we reached out to your usual CROs, saying that we are into COPD space, and they all try to sell us inflammation models. Naturally, this was not what we were looking for, so we had to kind of redevelop one old model of our own, which is the SO2 challenge model, which is a kind of harsh model. So you are exposing, you're pre-treating your animals for a certain type of weeks, and then you're exposing them with sulfur dioxide for a few hours, and we have titrated this quite carefully. And to check the leakage, we are injecting human serum albumin in the tail vein of the animals. After we sacrifice them, we take out the lung fluid, we do a bulk lavage, and then we measure the amount of human albumin in that fluid. Now, of course, again, there is no active transport of human albumin over a lung bed. So the only way that we can detect albumin in the lung is that it actually has to be a rupture in the lung. And this is exactly what we see if we challenge them with SO2 and then treat them or check them with human albumin. And what we also can see, which is borderline science fiction to me, is that if we pre-treat our animals for 2 weeks with some of our compounds, we can actually limit up to 95% of the damage done by sulfur dioxide. So with this data in mind, we then went back to the CROs and said, okay, now we can talk about inflammation, because we proved our point. We are affecting the epithelium and the leakage and the barriers. Then we went back to the workhorse model in COPD, which is the LPS challenge model. And here we could show that we are having a superior effect on LPS challenge as well. We are as good as dexamethasone, which is the positive control. But for us, it was important to do it in this way, that we first proved the epithelium point with the SO2 model, and then move on to the LPS model. If we only had this model, we might still believe that we only have an anti-inflammatory drug, and that's not really what we're trying to develop here. Sorry, our patent portfolio is surprisingly strong. It turned out there's a lot of people working on 15-membered macrolides, such as azithromycin, but they've all been doing it with a focus on getting new antibiotics. So that field is completely crowded. As soon as you chemically remove the places on the molecule to account for the antibiotic activity, it was a complete barren landscape. So our problem is now kind of the reversed. The EPO has already, after 3 years, sent us the intention to grant letter. So we're trying to postpone that for as much as we can, so we don't have to go into national phase too early, because it costs us too much. But we have done our FTO search. It's freedom to operate and quite a young patent, which is good. So just briefly on the management team, we have me as a CEO. I've been doing this for 15 years now, and taking molecules from preclinical into clinic is apparently what I do in life. We have Fredrik Garrason, which is the